everyone to our week 5 lab prep, and we are discussing wound care this week. So today we're going to discuss the normal process of wound healing, including primary and secondary intention. We'll describe the complications of wound healing, including the factors that impede or promote wound healing. We're going to discuss the components of a wound assessment and distinguish normal and abnormal findings, and outline the nursing management for a client with a surgical drain and the process for suture and staple removal. So the process of wound healing. So wound healing comprises an integrated physiological process. And so quite a bit goes on in your body when you're trying to heal a wound. There's two types of wounds, and those are one with tissue loss and those without. So a clean surgical incision is an example of a wound with little tissue loss. And the surgical wound heals by something we call primary intention. The skin edges are approximated or closed by the surgeon, and the risk of infection with primary intention is low. Healing tends to occur quickly with minimal scar formation as long as infection or secondary breakdown are prevented. Now, in contrast, a wound involving loss of tissue, such as a burn, a pressure injury, or a severe laceration, heals by secondary intention. The wound edges are not approximated, and so that means that they're not surgically closed, and healing occurs from the bottom up, from the wound bed up. So it occurs by granulation tissue formation and contraction of the wound edges. The wound is left open until it becomes filled by scar tissue. It takes longer for a wound to heal by secondary intention, and so the chances of infection are higher. If scarring from secondary intention is severe, you may have loss of tissue function, which can be permanent. So these are an example. So the top is primary intention. You see an open wound that's been closed by sutures, and you end up with a fine scar. Whereas secondary intention, you can see that the wound is left open and it heals from the bottom up, and you will have a scar in that place. So these are the complications of wound healing: hemorrhage, infection, dehiscence, evisceration, and fistulas. And I'll discuss those on the next slides. So hemorrhage is normal during or after trauma or surgery, and it's usually controlled by hemostasis, so our clotting mechanisms within our body, and it's usually controlled within minutes. If there is post-hemostasis bleeding, it could signal that there's a suture that's been pulled, there's a clot that's been dislodged, maybe there's infection, or maybe a blood vessel has been eroded. And so internal hemorrhage, you get swelling at the site, you could get distension, increased drain output, and in severe cases, if there's a lot of hemorrhage, the patient could go into hypovolemic shock. A hematoma is a localized blood collection. You get swelling, you get a bluish discoloration, and it could, if the hematoma is large, it risks putting pressure on the vessels nearby. External hemorrhage, you will see visible bleeding, you'll see soaked dressings and blood pooling. And it's most common in the first 24 to 48 hours post-surgery if it's going to happen. Infection is the second most common healthcare-associated infection from a wound. All chronic wounds are considered contaminated, and infection is defined by greater than 100,000 organisms per grams per tissue. The risk factors are necrotic tissue, so not getting enough blood supply to the tissue, contamination for some reason, and reduced blood supply. The signs are fever, tenderness. You could have an elevated white blood cell count, inflamed edges, and purulent drainage. The drainage color may be yellow, green, or brown depending on the organism, and it may appear 2 to 5 days post-injury or surgery. Dehiscence is the partial or total separation of the wound layers. It's most common 3 to 11 days post-injury. The risk factors are an underlying infection around the wound care site, someone who is obese, poor nutrition, so you're not healing well, and sudden strain, so someone's coughing or vomiting. Patients often say it's like something is given away sensation, so it's opened up. and you're going to have an increased serosanguinous drainage at the site. And the prevention is support the wound during coughing with a pillow or blanket. So this is an example of a dehiscence. So you can see the wound edges have come apart. Now, evisceration is total wound separation with organ protrusion. It's an emergency situation. It requires surgical intervention. The immediate actions would be you to cover with sterile saline soaked towels, keep the patient MPO, monitor for shock, call the physician or the surgeon, and prepare for surgery. And this is an example of evisceration. So you can see the intestines have come through here. And then fistular formation is an abnormal connection that develops between organs or organ in the skin. The causes are poor healing, trauma, infection, Crohn's disease, or cancer. The risks are infection, fluid and electrolyte imbalances, chronic drainage, and you can have skin breakdown from continuous fluid loss. And this is an example of a GI fistula, so you can see that there's an erosion between the loops of the bowel here. So moving on to surgical wound assessment, there's certain things that you need to look at when you're doing your wound assessment. So if we start at the top left, the appearance. So note the color of the wound. Is there any bruising, redness, and approximation of the incision? So that means, are the edges well approximated? Are they together? The size, note the length, the width, the depth, and shape of the wound and any signs of the wound opening. So this is talking about dehiscence or evisceration, and this is where you would measure the wound with a tape measure. Is there any exudate? So check the wound for exudate. Is it watery? Is it purulent? Does it smell? What's the amount? A small amount of serous drainage is common, and it changes from sanguinous, which is red, to serosanguinous, which is pink, to serous, which is clear yellow. And that's the normal progression of surgical drainage. And drainage will decrease over time. Edema. Is there excessive swelling at the wound site? And this can indicate wound complications. Pain. Does the patient have sudden onset or persistent severe incisional pain? May indicate infection, hemorrhage, or hematoma. And then, is there a drain? Note the placement and security of the drain or tube. Check the collection device and empty as required and document the findings. So basic skin cleaning for surgical wounds. So a surgical or a traumatic wounds are cleaned by applying a non-cytotoxic solution, typically saline, with a sterile gauze or through irrigation. The following principles are important when cleaning an incision or the area surrounding a drain. And I do have pictures of these on the next page. So you're going to clean in the direction from the least contaminated area, such as from the wound or the incision to the surrounding skin, or from an isolated drain site to the surrounding skin. Use gentle friction when applying solutions locally to the skin, and you would never use the same piece of gauze to clean across an incision or the wound twice. It's always a new piece of gauze, and you use the gauze to clean the peri-wound skin, so the wound around the skin, not the open wound. Open wound beds are damaged by the abrasive contact of gauze. So on the left, you see clean in the direction from the least contaminated area, such as from the wound or incision to the surrounding skin. And you can see here, if you look at the numbers, you go from one out, two out. Or the other way is you were cleaning from the top to the bottom of the wound. So you can clean down the wound. So you would clean down and then up, and you can see the directions there. Or if you're cleaning around a drain site, you would start from the drain site and then go out to the surrounding skin. So if an open drain leaks onto the surrounding skin, the nurse must ensure that the drainage is removed fairly quickly from the skin to avoid maceration or excoriation of the tissues from whatever it is that's draining. And the drain itself may also need to be regularly cleaned to avoid a buildup of possible contaminated materials. Barrier wipe is applied to the skin around the drain site to protect it from maceration. And so the drain sites are a source of contamination because they're a moist drainage because a moist drainage harbors microorganisms. And if a wound has a dry incisional area but a moist drain site, the nurse should use two separate swabs or gauze pads, one to clean from the top of the incision towards the drain and one to clean from the bottom of the incision towards the drain. To clean an isolated drain site, clean around the drain, which is on the picture I showed you, moving in a circular rotation outward from a point closest to the drain. And so similar to that, the picture I showed a couple slides back. In this situation, the site near the site is more contaminated than the site itself. And you to clean a circular wound, you would use the same technique as in cleaning around a drain. So from the inside, the dirtiest, to the outside, and using a different swab each time. So next we're going to look at, there's different types of drains. We're going to look at a patient that has a hemovac, who has a Jackson-Pratt, who has a Penrose drain, and then we're going to look at sutures and staple removals, and they're all in the form of videos.
It's Nurse Samantha, and this is my patient Hector. And today I'll be teaching you how to drain a hemovac. So as you can see right here, Hector just had knee surgery, so we're assuming that he's going to be draining a lot of fluid out. Compared to a Jackson-Pratt drain, aka a JP drain, it holds 100 milliliters compared to the hemovac, which is 400 milliliters, so a much bigger reservoir. This also works by suction, and as you can see, it's fully expanded, so it's not really functioning the way that it should be, so we need to completely drain the back. So I have my towel ready just to protect Hector's sheets. I'm going to put that under here. I have my collection cup. And then what I want to do is I simply just want to open this up away from you. And then getting my cup ready, we're going to squeeze all the fluid out. And then we would also want to assess the color and then how much Hector is draining out.
Looks like urine.
We're done with the silly comments. We're gonna we're gonna keep squeezing it, and then we're gonna put the cap back on. And then again, we just want to make sure that this isn't gonna tug on the patient, come out of the patient. So it's gonna be clipped to the patient's gown. Thank you. Hi, it's Nurse.
Okay, so next we're moving on to the Jackson-Pratt or a JP drain.
A JP drain is a suction device in which the drain itself is inside the body. It's made of Teflon and has multiple drainage holes. The drain is connected to clear plastic tubing that is usually sutured to the skin where it leaves the body. The tubing connects to a bulb reservoir. That bulb, when squeezed empty, applies constant suction and pulls excess fluid out of the body. The drain is removed when the excess fluid has stopped draining from the body. You will need the following supplies to perform drain care. A cup provided by your nurse at discharge. A sheet of paper to record the amount of drainage. Caring for your drain is a clean procedure, which means supplies do not need to be sterile, but you must wash your hands thoroughly with soap and warm water before and afterwards. Empty the bulb at least 3 times per day and more as needed. If the drain tube becomes clogged or is not draining properly, you can milk the tube. Gently squeeze the tube between your thumb and index finger, moving your fingers along the tubing toward the suction bottle to help dislodge the obstruction or blood clot. Use liquid soap or hand sanitizer to help your fingers glide over the tubing. You should milk the tube twice a day. After milking the tube, empty the drain. Pull the stopper out of the bulb and empty the drainage fluid into the measuring cup provided to you by your nurse when you were discharged. Record the amount of drainage fluid on your record sheet. Dispose of the drainage fluid in a toilet or rinse it down the sink. Re-establish the suction. Squeeze the bulb in the palm of your hand until the inside walls of the drain touch. While maintaining pressure, replace the plug. Slowly release your grip to re-establish suction. The bulb should remain concave or somewhat flat. It should not be fully inflated. If the bulb is not flat, the suction is not working. When to call the doctor. If the drainage suddenly stops, the drainage should decrease gradually, not abruptly. If there's a sudden change in the color of the drainage should gradually change from blood to straw-colored fluid. If the drainage becomes bloody again or changes to a milky white fluid. If there is an increase in redness or swelling around the insertion site of the drain. If you are unable to re-establish suction in the drainage system. If you have any other questions at all, please don't hesitate to ask. We're here to help.
So this is just a picture of a Penrose drain. So you can see this is coming out of the jaw, and oftentimes, so this will be removed by the surgeon, but your job would just be to clean around it. So next we're going to look at staple removal. So that was staple removal. So you can see it's actually a special staple remover that's used for the metal staples. You would clean the wound first, and then you would remove the staples, and if needed, clean afterwards. Otherwise, it's left open to the air. Okay, removing sutures is the next one.
With our tweezers, cut that part of the thread, lift up and pull over the wound. Make sure it's intact, drop it into your gauze. Grab the knot, snip underneath it, lift up, and then pull over the wound and drop in the gauze. Take a new antiseptic swab and clean the areas where you remove the suture. Whenever you're applying steri strips, you want to gently lay down one part of it, smooth it down, and then gently lay down the other side. Don't pull it to create tension. Smooth it down and then gently lay on the other side. Grab your knot, cut underneath, pull up, and then over. Place in the gauze. Cut underneath and lift up and pull over and drop it in the gauze. Grab the knot, cut underneath, lift up a little bit, and then pull over. Take a new antiseptic swab, clean those areas 3/4 inch on each side of the incision, about 1/8 inch apart.